It is known that submucosal myomas do cause pregnancy problems. There are histories of recurrent miscarriages, premature labor, abnormal presentations. There are various complications of labor, so these are very important for the clinician to know about. Now, when the submucous myoma is on a stalk, that sets up a predisposition to a torsion of this myoma, and that can lead to a painful episode, necrosis, bleeding, etc., and the rest of the story you can imagine from this wonderful drawing of Dr. Netter. They can also prolapse. They prolapse out through the cervix, and here's transvaginal representation. Here's the cervix. Here's the anterior cervical wall. This is the posterior cervical wall. Internal os is about here, and the fibroid bulges out through the external os. And color Doppler adds a very important piece of information that there's a thick vascular stalk feeding this fibroid. We can alert the clinician then that there could be excessive bleeding during the surgical removal. Now you could say, well, why do you have to do transvaginal sonography if the clinician can see this from a pelvic exam? Well, you certainly want to know what else is going on in this patient, and sometimes lately we find that our emergency rooms are just sending patients to us for whatever reason that they come without having a pelvic exam prior to the ultrasound. So this can be completely unexpected. And that is one of the reasons why the cervix has to be looked at separately from the rest of the corpus, because you could easily miss this protrusion if you do not include the entire cervix in your transvaginal image. The prolapsing submucous myoma can be, especially the ones coming from the fundal part of the uterus, if they're fairly big and on a thick stalk, they can, as they protrude, they can actually pull the soft uterus with it and cause an inversion. And here it protrudes out the vaginal introitus. And look what happens. I'll back that up again. This is the serosal lining. This is the endometrial lining. So as it pulls out, this is the exposed endometrium, and the serosal surface is now in here. So this can be quite a problem, can invert and pull a considerable amount of uterus with it. Subserosal myomas tend to be removed laparoscopically, so we have to tell them the percentage. In this case, over 50% of this myoma is subserosal. In this case here, it protrudes from the entire lateral wall, and one would have to think about this, how much of the wall would be exposed if this was removed. Perhaps this has to be converted into a laparotomy for surgical removal. When a subserosal myoma becomes very large, usually about over 8 centimeters in size, then it's usually removed by laparotomy. Subserosal myomas can be pedunculated. Now this is if they are on a stalk. So what is a pedicle? What exactly do we have to have? That's difficult to define, and many gynecologists don't exactly know when to call it a pedunculated myoma, but I have seen in the literature description that the diameter of the pedicle when it's less than 50% of the diameter of the myoma, then that's considered a stalk, a broad-based or thin stalk, whatever. This patient, these patients with these pedunculated myomas are considered not good candidates for uterine artery embolizations because they then may necrose and slough off, the uterus and cause abdominal symptoms. Now, another problem with these is that if you do transvaginal sonography alone, you may only include the entire uterus, but cut off this large mass that's protruding from the fundus. So that's a pitfall of transvaginal sonography, such as here. Here we fit in the uterus, pretty much, not even the cervix, but there was a pedunculated myoma here attached. It was completely cut off the image. So if one has the transabdominal image first, it is very helpful then with your transvaginal exam. Now some of these pedicles, these stalks, can be very thin and long. Years ago, and this is many years ago, in the days of static scanning, and I often like to throw in a static scan just to remind us of the history of ultrasound, how far we've come with our technology. But this woman had a mass that wandered around her abdomen and pelvis. It was a solid mass that kept moving around. And one day she developed severe pain. They opened her up. It was a torsed pedunculated myoma on a very long stalk. So one day it just twisted somehow on its pedicle and necrosed. So this was kind of a wandering myoma, kind of similar to a wandering spleen, if you've ever heard of those. Now, the diagnosis of pedunculated myoma has to be made with caution because this is a solid mass adjacent to the uterus, and it could be an ovarian tumor. So it is crucial, before we call a pedunculated myoma, to find a separate ovary. Once we do this, we can then study the relationship of this solid mass to the uterus. One thing is to look for feeding vessels. The vessels coming through the stalk, these can be confirmed with color. Here in this case, this was the uterus. This is a pedunculated myoma. There was a separate ovary, and now we confirm that the blood supply to this mass is coming from the uterus. Masses are, if you don't know an origin of a mass, it's very helpful many times to find what vessel is feeding it, and that helps you sometimes define the origin. We know this from CT, for example. If there's a pelvic mass and we can trace the gonadal vessel, the ovarian vessels to that mass, then it's most likely of ovarian origin. It's a fairly good assessment. So in this case, we have vessels crossing through that vascular stalk, which then sets it up for possibility of a torsion. So if a patient has a known myoma and then one day comes in with severe pain, certainly you have to think of torsion. This lady came in with pain and didn't know she had one, but this is a solid mass, very solid, intimately related to the uterine wall. Ovaries were separate. There was no blood flow in this mass, very tender. Patient goes to surgery, and it is a torsed pedunculated myoma. Another patient, large myoma, no internal flow, now it's extremely tender, has to go to surgery. It's a torsed myoma. Sometimes the subserosal myomas have such a broad connection to the surface of the uterus that we have to provide this information to the gynecologist so they can plan, again, their surgery. Now look at this uterus. Here's the uterus. The ovary was separate and arising from the entire anterior wall with large feeding vessels, confirmed here with Doppler, feeding this huge mass. Something like this cannot be removed from the entire wall with so many vessels to deal with.